Medicare coverage, and payment of virtual services. This video will provide you with answers to common questions about the Medicare Telehealth Services benefit. CMS is expanding this benefit on a temporary and emergency basis under the 1135 Waiver Authority and Coronavirus Preparedness and Response Supplemental Appropriations Act, building on prior action to expand reimbursement for telehealth services to people with Medicare. Interim Final Rule with Comment Period, IFC, CMS 1744 IFC, dated March 30, 2020. Further expanded this benefit on a temporary and emergency basis, retroactive to March 1, 2020. CMS is expanding access to telehealth services for people with Medicare. This means they can receive care where they are, at home, or in a nursing or assisted living facility. If they have COVID-19, they can remain in isolation and prevent spreading the virus. If they aren't infected, they can get care without risking exposure to others who may be ill. Let's begin with what are telehealth services. Telehealth, telemedicine, and related terms generally refer to the exchange of medical information from one site to another through electronic communication to improve a patient's health. During the pandemic, individuals can use commonly available interactive apps to visit with their clinician. Any technology with audio and video can be used. Who can provide telehealth services? Distant site practitioners who can furnish and get payment for covered telehealth services subject to state law can include physicians, nurse practitioners, physician assistants, nurse midwives, certified nurse anesthetists, clinical psychologists, clinical social workers, registered dietitians, and nutrition professionals. In addition, in many cases, CMS is allowing physicians to supervise their clinical staff using virtual technologies when appropriate, instead of requiring an in-person presence. What can Medicare pay for? Medicare can pay for office, hospital, and other visits furnished via telehealth across the country, and including in patients' places of residence. People with Medicare can receive care where they are, at home or in a nursing or assisted living facility. If they have COVID-19, they can remain in isolation and prevent spread of the virus. If they aren't infected, they can get care without risk of being exposed to others who may be ill. What services can a Medicare beneficiary receive through telehealth? Medicare beneficiaries will be able to receive a specific set of services through telehealth, including evaluation and management visits, common office visits, mental health counseling, and preventive health screenings. With the March 30th IFC, CMS will now allow for more than 80 additional services to be furnished via telehealth. Telehealth visits include emergency department visits, initial nursing facility and discharge visits, home visits, and therapy services, which must be provided by a clinician that is allowed to provide telehealth. New as well as established patients now may stay at home and have a telehealth visit with their provider. During the public health emergencies, individuals can use interactive apps with audio and video capabilities to visit with their clinician for an even broader range of services. These temporary changes will ensure that patients have access to physicians and other providers while remaining safely at home. What requirements does telehealth fulfill? CMS is allowing telehealth to fulfill many face-to-face visit requirements for clinicians to see their patients in inpatient rehabilitation facilities, hospice, and home health. How does telehealth help with remote patient monitoring? CMS is making it clear that clinicians can provide remote physiologic monitoring services to patients with acute and chronic conditions, and can be provided for patients with only one disease. For example, remote monitoring can be used to monitor a patient's oxygen saturation levels using pulse oximetry. What about home health? Home health agencies can provide more services to beneficiaries using telehealth, so as long as it's part of the patient's plan of care and does not replace needed in-person visits as ordered on the plan of care. If a physician determines that a Medicare beneficiary should not leave home because of a medical contraindication or due to suspected or confirmed COVID-19, and the beneficiary needs skilled services, he or she will be considered homebound and qualify for the Medicare home health benefit. As a result, the beneficiary can receive services at home. What about hospice care? Hospice providers can also provide services to a Medicare patient receiving routine home care through telehealth, if it is feasible and appropriate to do so. CMS maintains a list of services that are normally furnished in person that may be furnished via Medicare Telehealth. This list can be found at https://www.cms.gov/medicare/general-information/telehealth/telehealth-codes. What are the types of virtual services? Even before the availability of this waiver authority, CMS made several related changes to improve access to virtual care. In 2019, Medicare started making payment for brief communications or virtual check-ins, which are short, patient-initiated communications with a healthcare practitioner. Medicare Part B separately pays clinicians for e-visits, which are non-face-to-face patient-initiated communications through an online patient portal. There are four main types of virtual services physicians and other professionals can provide to Medicare beneficiaries: Medicare telehealth visits, virtual check-ins, e-visits, and telephone services. Let's take a look at each type of virtual service. Medicare telehealth visits. Currently, Medicare patients may use telecommunication technology for office, hospital visits, and other services that generally occur in person. The provider must use an interactive audio and video telecommunications system that permits real-time communication between the distant site and the patient at home. During the public health emergencies, individuals can use interactive apps with audio and video capabilities to visit with their clinician for an even broader range of services. What about cost sharing? Additionally, the HHS Office of Inspector General, OIG, is providing flexibility for healthcare providers to reduce or waive cost sharing for telehealth visits paid by federal healthcare programs. Here are some key takeaways about Medicare telehealth visits. Medicare will make a payment for Medicare telehealth services furnished to patients in broader circumstances. These visits are considered the same as in-person visits and are paid at the same rate as regular in-person visits. Medicare will make payment for professional services furnished to beneficiaries in all areas of the country in all settings. Medicare will make payments for Medicare telehealth services furnished to beneficiaries in any healthcare facility and in their home. There is flexibility for healthcare providers to reduce or waive cost sharing for telehealth visits paid by federal healthcare programs. Virtual check-ins. In all areas, not just rural, established Medicare patients in their home may have a brief communication service with practitioners via a number of communication technology modalities, including synchronous discussion over a telephone or exchange of information through video or image. We expect that these virtual services will be initiated by the patient. However, practitioners may need to educate beneficiaries on the availability of the service prior to patient initiation. Virtual check-in services, or brief check-ins between a patient and their doctor by audio or video device, could previously only be offered to patients that had an established relationship with their doctor. Now, doctors can provide these services to both new and established patients. The patient must verbally consent to at least once a year to receive virtual check-in services. The Medicare coinsurance and deductible would generally apply to these services. The practitioner may respond to the patient's concern by telephone, audio-video, secure text messaging, email, or use of a patient portal. Standard Part B cost sharing applies to both. In addition, separate from these virtual check-in services, captured video or images can be sent to a physician. HCPCS code G2010. Key takeaways about virtual check-ins are: service is not limited to only rural settings or certain locations. Patient must agree to the virtual service. Use HCPCS code G2012 or HCPCS code G2010. Virtual check-ins can be conducted with a broader range of communication methods, unlike Medicare telehealth visits, which require audio and visual capabilities for real-time communication. E-visits. E-visits are non-face-to-face patient-initiated communications through an online patient portal. In all types of locations, including the patient's home, and in all areas, not just rural, established Medicare patients may have non-face-to-face patient-initiated communications with their doctors without going to the doctor's office by using online patient portals. The Medicare coinsurance and deductible will apply to these services. Codes for practitioners who may bill independently. Medicare Part B also pays for e-visits or patient-initiated online evaluation and management conducted via a patient portal. Practitioners who may independently bill Medicare for evaluation and management visits, for instance, physicians and nurse practitioners, can bill the following codes: 99421, 99422, 99423. Codes for practitioners who may not bill independently. Clinicians who may not independently bill for evaluation and management visits, for example, physical therapists, occupational therapists, speech-language pathologists, clinical psychologists, can also provide these e-visits and bill the following codes: G2061, G2062, G2063. Key takeaways for e-visits include: this is not limited to only rural settings. There are no geographic or location restrictions for these visits. Patients communicate with their doctors without going to the doctor's office by using online patient portals. Individual services need to be initiated by the patient. However, practitioners may educate beneficiaries on the availability of the service prior to patient initiation. The services may be billed using CPT codes 99421 through 99423 and HCPCS codes G2061 through G2063 as applicable. The Medicare coinsurance and deductible would generally apply to these services. Telephone services. Telephone services describe evaluation and management, EM, or assessment and management services furnished by a physician or qualified healthcare professional via telephone or online. Codes for telephone services include 99441 through 99443 and 98966 through 98968. This chart summarizes the types of telehealth service and requirements and includes the information you will need to bill correctly. This chart and other helpful information can be found in the Medicare Telemedicine Healthcare Provider Fact Sheet at https://www.cms.gov/newsroom/fact-sheets/medicare-health-care-provider-fact-sheet. Are there any other professional services that Medicare covers? Medicare pays separately for other professional services that are commonly furnished remotely using telecommunications technology without restrictions that apply to Medicare Telehealth. These services, including physician interpretation of diagnostic tests, care management services, and virtual check-ins, are normally furnished through communication technology. How does a qualified provider bill for telehealth services? Medicare telehealth services are generally billed as if the service had been furnished in person. During the PHE for the COVID-19 pandemic, Medicare telehealth services claims should reflect the designated POS code for the location where the service would have occurred in person, and modifier 95 to indicate that the billed service was furnished as a professional telehealth service from a distant site. However, consistent with current rules for traditional telehealth services, there are 3 additional scenarios where modifiers are required on Medicare telehealth claims. In cases when a telehealth service is furnished via asynchronous, store and forward technology as part of a federal telemedicine demonstration project in Alaska and Hawaii, the GQ modifier is required. When a telehealth service is billed under CA Method 2, the GT modifier is required. Finally, when telehealth service is furnished for purposes of diagnosis and treatment of an acute stroke, the GO modifier is required. When billing claims for telehealth services with dates of service on or after March 1, 2020, and for the duration of the public health emergency, PHE bill, with the place of service, POS, equal to what it would have been in the absence of a PHE, along with a modifier 95, indicating that the service rendered was actually performed via telehealth. As a reminder, CMS is not requiring the CR modifier on telehealth services. How much does Medicare pay for telehealth services? Medicare pays the same amount for telehealth services as it would if the service were furnished in person. Can hospitals, nursing homes, home health agencies, or other healthcare facilities bill for telehealth services? Billing for Medicare telehealth services is limited to professionals. Like other professional services, critical access hospitals can report their telehealth services under COM Method 2. If a beneficiary is in a HealthCare facility, even if the facility is not in a rural area or not in a health professional shortage area and receives a service via telehealth, Medicare makes payment to the distant site practitioner for the professional services. For the service furnished via telehealth, the healthcare facility would only be eligible to bill for the originating site facility fee, which is reported under HCPCS code Q3014. Should on-site visits conducted via video or through a window in the clinic suite be reported as telehealth services? Services should only be reported as telehealth services when the individual physician or professional providing the telehealth service is not at the same location as the beneficiary. That doesn't mean that service conducted via a video or through a window cannot be reported. This concludes our overview of Medicare coverage and payment of virtual services. This educational product was prepared as a service to the public and is not intended to grant rights or impose obligations. This educational product may contain references or links to statutes, regulations, or other policy materials. The information provided is only intended to be a general summary. It is not intended to take the place of either the written law or regulations. We encourage readers to review the specific statutes, regulations, and other interpretive materials for a full and accurate statement of their contents. The Medicare Learning Network, MLN Connects, and MLN Matters are registered trademarks of the U.S. Department of Health and Human Services, HHS. Paid for by the Department of Health and Human Services.